My topic for this session is Pathophysiology, Preventive Strategies, and Recent Advances of Necrotizing Enterocolitis. So, specific learning objectives for this session are introduction, then pathophysiology of necrotizing enterocolitis, followed by preventive strategies and recent advances in management of necrotizing enterocolitis along with pathophysiology, and at last conclusions. So, starting with introduction, necrotizing enterocolitis is a devastating inflammatory intestinal disease mainly affecting preterm neonates, which is characterized by variable intestinal injury extending from epithelial injury to transmural involvement and perforation, which may lead to sepsis or death. It is often marked by inflammation and bacterial invasion. So, why is it important to discuss various aspects of disease? Because NEC is one of the leading causes of morbidity in preterms. It affects around 5 to 7% of preterm babies and 10% of very low birth weight preterm. Mortality rate for VLBW babies with NEC is 10 to 30%, and it is 30 to 50% in case of extremely low birth weight babies with NEC. This increased incidence of NEC is attributed to improvement in neonatal care and better survival of premature infants over time. So these babies who survive NEC have high chances of several complications like neurodevelopment and growth impairment, which adds to the morbidity of children. So it is of utmost need to further evaluate pathophysiology of necrotizing enterocolitis so as to make more appropriate preventive strategies and make early diagnosis along with early and effective treatment. So coming to complications and outcomes in patients with necrotizing enterocolitis, these can be basically divided into two groups. First group include complications that could occur in relation to bowel disease, surgical treatment performed, and length and quality of residual bowel left. So the first complication being recurrence, which is seen in around 4 to 10% of babies with NEC, and associated factors include non-operative management as well as babies with congenital heart disease. Mortality is seen in 15 to 63% of babies with NEC, especially in low gestational age newborns. Intestinal strictures is seen in 12 to 35% babies with NEC, and it is most frequently present in babies managed medically, and it affects colon in up to 80% of cases. Stoma complications like prolapse, stricture, and retraction are seen in 50% of babies with NEC. Short bowel syndrome with complications like catheter-related infection, sepsis, cholestatic liver disease, and liver failure is seen in around 20 to 35% of babies with NEC, and its increased risk is associated if residual intestinal length is less than 25% length of gestational age. And the second group of complications include long-term complications like neurodevelopment impairment and chronic lung disease. So neurodevelopmental impairment, this is the most important long-term morbidities in babies with NEC. NEC is associated with an inflammatory reaction that results in hypoxia and ischemia that may influence the outcome of neurological development of newborns. Babies with NEC may have cerebral palsy, deafness, blindness, defective learning, memory, and defective social interactions as neurodevelopmental impairment. And this is seen in around 30 to 50% of babies with NEC, especially in surgically treated NEC. Apart from all these complications, one of the most important effects of NEC is lung injury, and is characterized by persistent and prolonged ventilatory requirement, and it is seen in 53% of babies with NEC, especially in extremely low gestational age newborns. So preventive strategies should be developed to avoid all these complications. Coming to the pathophysiology of NEC, this is basically multifactorial, and it includes a combination of impaired intestinal perfusion along with abnormal bacterial colonization, impaired gut barrier function, and immature and overactive immune response. And these all leads to intestinal inflammation, ischemia, and eventual necrosis. So there are many risk factors for the development of necrotizing enterocolitis. Important maternal factors being chorioamnionitis, lack of prenatal steroids, mode of delivery, and history of maternal smoking. Other factors being acid suppressing medications, antibiotic exposure, which mainly lead to gut dysbiosis causing NEC, blood transfusions, and poor intestinal perfusion. So the main risk factor which has been consistently associated with NEC includes low birth weight or prematurity with altered host defense with immature host system and formula feeding, dysbiosis, and bowel ischemia. All these factors lead to necrotizing enterocolitis. So main factors associated with pathogenesis include, first is toll-like receptor 4, which is the key mediator in NEC pathogenesis, and it has been seen that there is increased expression of TLR4 in preterm intestinal epithelium, which is activated by lipopolysaccharide of gram-negative bacteria, leading to an inflammatory cascade. Second main factor of pathogenesis of NEC is gut dysbiosis. This involves a lack of beneficial commensal microbes and low diversity of bacteria. Third being nitric oxide, it leads to formation of peroxynitrite, which is a potent oxidant, and this leads to intestinal tissue injury. And another factor is bowel microvascular flow obstruction. This is mainly associated with feeding and postprandial hypoxia and transfusion related acute gut injury. Fourth, reduced activity of intestinal stem cells. This is the recent factor being investigated in NEC pathogenesis, and it has been studied that NEC is characterized by a decrease in LGR5 positive intestinal stem cells. So this is the model for the pathogenesis of NEC based on bacterial signaling through toll-like receptor 4 on the premature intestinal epithelium. In the healthy intestine, bacterial colonization of GIT occurs without inducing an inflammatory response. While in healthy premature infant, there is increased expression of toll-like receptor 4 due to its role in regulating normal intestinal stem cell differentiation. So, if preterm has higher chances of having dysbiotic microbiome, and along with factors of NEC predisposition like prematurity, formula feeding, and hypoxia, these all leads to toll-like 4 receptor activation. And this leads to increased enterocyte apoptosis and necrosis, along with impaired restitution of mucus with reduced proliferation of enterocytes. Also, TLR4 signaling induces the accumulation of pro-inflammatory lymphocytes, which contribute to the barrier injury through interleukin-17 release. This barrier breakdown facilitates gut bacteria translocation, which can interact with toll-like receptor 4 on endothelial lining, leading to reduced endothelial nitric oxide synthase. This leads to mesenteric vasoconstriction and then impaired perforation, along with platelet dysfunction, inflammasome activation, and DNA methylation. All this leads to NEC development. So this slide shows the immunoinflammatory physiology in NEC. Intraluminal bacteria disrupt and invade the intestinal epithelium, and these endotoxin released bind to toll-like receptor 4 present in intestinal epithelium. This activate pathogen-associated molecular pattern, and gut barrier breakdown occurs. This causes bacterial translocation along with intense inflammatory response in form of TNF-alpha release and interleukin-1 beta release. Vasoactive substances like platelet activating factor, endothelin-1, and nitric oxide are also released. These all leads to complement and coagulation system activation, followed by microvascular blood flow obstruction due to adherence of leukocyte and platelet in the endothelial wall. This causes impaired vasorelaxation of the microvasculature, and finally leading to intestinal tissue injury and characteristic necrotizing enterocolitis. This shows the pathogenesis of NEC affecting other organs apart from gut. Children who survive NEC often have long-term complications, the most clinically significant of which is its effect on lung and brain. So, the pathogenesis of lung injury include release of high mobility group box 1 from newborn intestine, which activates pulmonary epithelium toll-like receptor 4, and this leads to release of chemokines, which causes influx of neutrophils in the lung, causing lung injury. And the mechanism for brain injury includes the release of HMG-B1 from inflamed intestine, which causes microglia activation and release of reactive oxygen species, along with oligodendrocyte progenitor cell loss and myelin loss. This contributes to brain injury. So oral administration of ROS scavenger along with the dendrimer may reduce neurological dysfunction. This is under trial. And this shows the development of normal gut microbiota. In early postnatal period, facultative anaerobes like Enterococcus coliform, Streptococcus, and Staphylococcus colonize the intestinal epithelium. This stage is influenced by genetics as well as mode of delivery and is considered essential for colonization by strict anaerobes like Bifidobacteria. From postnatal age date 4 to 10, there is relative abundance of bifidobacteria along with bacteroids and clostridia. This is influenced by feeding type and environmental exposure. So this is the normal gut microbiota pattern. While in preterm infants, they have a different gut microbiota, including reduced species diversity, higher number of enterobacteriaceae, including Klebsiella pneumonia and E. coli and Clostridium difficile, and reduced number of bifidobacteria and lactobacilli. So preterm babies have higher chances of having gut dysbiosis leading to NEC. So these are all the factors which influence the gut microbiota development in early life. During pregnancy, factors like maternal microbiota, nutritional status, lifestyle, and genetics of mother influences gut microbiota of newborn. At birth, gestational age, intestinal immaturity, and delivery mode, along with antibiotic exposure, influences the gut microbiota development. During infancy, feeding time, antibiotic exposure, and family environment as well as geographical location affects gut microbiota development in early life. So this graph shows that breastfed babies have abundance of bifidobacterium, while in formula-fed babies there is equal abundance of bifidobacterium and bacteroids. So this is the slide showing a disruption of gut microbiota development and its homeostasis, that is gut dysbiosis. In the first image, there is eubiosis, meaning there is prevalence of non-pathogenic bacteria, which causes normal mucus production and maintains gut barrier by translocating tight junction protein, and this results in immune homeostasis. While in case of dysbiosis, which is mainly seen in preterm babies, there is prevalence of pathogenic bacteria and decreased commensal bacteria. This causes alteration of tight junction with access of pathogen and release of lipopolysaccharide, and this causes inflammatory cascade with release of inflammatory mediators, and thus resulting in NEC. This study was published in Macrobiome in 2017. In this, intestinal dysbiosis in preterm infants preceding NEC was studied. This was a systematic review and meta-analysis, and it was concluded that microbial dysbiosis preceding NEC is in preterm infant is characterized by increased relative abundances of proteobacteria and decreased relative abundances of firmicutes and bacteroidetes. So microbiome optimization may provide a novel strategy for preventing NEC. And next is the role of nitric oxide in NEC pathogenesis. Intestinal barrier failure causes bacterial translocation along with endotoxin release. This causes inflammatory cascade in form of increased release of nitric oxide. This nitric oxide combines with superoxide, leading to formation of peroxynitrite, and this is a potent oxidant. This adds to enterocyte apoptosis and resulting in necrosis and characteristic NEC. This is another factor in NEC pathogenesis. Derangement of the intestinal microcirculation is seen in NEC. Areas of poor blood flow facilitate the inflammatory cascade. Also, feeding and postprandial hypoxia have been shown to synergistically induce intestinal hypoxia. Also, it has been seen that intestinal vascular autoregulation occurs after correction of anemia. So this results in transfusion-related acute gut injury because of decreased nitric oxide and in turn decreased vasorelaxation of microvascular. Now, this is the recent factor being studied in NEC pathogenesis, that is defect in intestinal stem cells and epithelial regeneration in NEC. Intestinal stem cells are responsible for producing progenitor cells, and these differentiate into various types of epithelial cells, including enterocytes, goblet cells, enteroendocrine cells, and Paneth cells. Intestinal stem cells are activated and replicate in response to intestinal injury, and NEC has been characterized by a decrease in LGR5 positive intestinal stem cells. So now coming after pathophysiology, coming to preventive strategies of necrotizing enterocolitis, antenatal steroids have been recommended in all preterm deliveries less than 34 weeks of gestation. This is one of the important prenatal preventive strategy for NEC. Early and exclusive human milk feeding has been advocated as one of the important measures for NEC prevention. Standardized enteral feeding, that is in form of minimal enteral nutrition at 20 to 25 ml per kg per day, has been recommended, and there should be awareness of potential risk factors for NEC like IUGR, sepsis, formula feedings, and various drugs, and all these should be avoided. Also, early diagnosis in form of suspicion if baby is having increased CRP, thrombocytopenia, persistent metabolic acidosis, and increased gastric residuals. This should be kept in mind, and early diagnosis of NEC should be made. Probiotics have been recommended by 2020 Cochrane review in preterm infants with low birth weight, and two molecules like lactoferrin and L-arginine have been is on under research before recommending it as the preventive strategy for NEC. So these four protocols should be followed in each center for NEC prevention. First is a standardized feeding protocol. Second, early initiation of enteral feeding using human milk. Third, optimization of the osmolality of preterm milk feeds using standardized dilution. Fourth, promotion of healthy microbiome by use of probiotics with early oral care with colostrum, with restricting high-risk medications, and prolonged use of empirical antibiotics should be discouraged. So there are two studies in antibiotics, use of antibiotics and NEC pathogenesis. First study was EpiPage 2 cohort study. This was published in year 2022, and they concluded that early antibiotic exposure was not associated with NEC, but it was associated with higher cerebral lesions. So it should be avoided. Also, another study published in 2020, in this, they studied the early use of antibiotic in preterm, that is within third day of life. The incidence of NEC was lower in the early antibiotic group, but it is important, but it cannot be generalized, and it is important to better understand the role of such variable like time, type, and duration of antibiotic treatment of NEC incidence, immune development, gut colonization, and antibiotic resistance in the NICU. So empirical use of antibiotic should be discouraged, and rational use of antibiotics should be done in all newborns. And exclusive human milk is the most important preventive strategy of NEC. There are several factors in human milk which is bactericidal, immunologic, and anti-inflammatory like nitrate, L-arginine, human milk oligosaccharide and prebiotic, lactoferrin. Breast milk also contain growth factors like epidermal growth factors and heparin binding growth factor, which deactivate toll-like receptor 4, which is the key mediator of NEC pathogenesis. And probiotics have been recommended by 2020 Cochrane review for NEC prevention. Probiotics are live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. Most commonly used probiotic strains being bifidobacteria and lactobacillus. So what are the functions of probiotic in NEC prevention? These decrease inflammation by decreasing activation of toll-like receptor 4 and decreasing NF-kappa B activation, which is a transcriptor for pro-inflammatory cytokines. These also compete against pathogens and generate metabolites involved in signaling, and it also tightens gut barrier. So these are all the functions of probiotics for NEC prevention. So this study was published in Cochrane database of systematic review. In this, they concluded that probiotics may reduce the risk of necrotizing enterocolitis. Now, role of H2 blockers in NEC. Ranitidine therapy was earlier used to protect infant from reflux-related apnea, but it has been studied that it is associated with increased risk of NEC, so it should be avoided in all newborns. And the concept of nil per orally during blood transfusion and NEC prevention. Earlier, it was assumed that baby should be kept nil per orally during transfusion, but this proposal was addressed in meta-analysis, and it does not demonstrate a reduction in transfusion as an associated NEC, so this should not be practiced. Now, coming to recent advances under biomarkers, several biomarkers are now available for early diagnosis of NEC. Non-specific markers for systemic inflammation include CRP, white cell count, thrombocytopenia, procalcitonin, serum amyloid associated protein, and platelet activating factors. While these are specific biomarkers for gut injury like calprotectin, intestinal fatty acid binding protein, and claudins, and fecal volatile organic compounds, along with several cytokines and cell surface antigens, are also available as biomarkers. Now, under genetic biomarkers, genetically programmed individuals are more prone to NEC. It has been studied, and research is ongoing to elucidate various genes which generate proteins involved in NEC development, like NF-kappa B1 variant in NEC, and various sequence variation in TLR pathway has been studied. Also, it has been studied that interleukin 18 genotype is more prevalent in stage 3 NEC as compared to stage 1 or 2. Under treatment, as toll-like receptor 4 is the key mediator of NEC pathogenesis, so its receptor inhibitor is under research, and various factors present in breast milk and in amniotic fluid, that is epidermal growth factor and heparin binding growth factor, along with vitamin D, has been under research for treating NEC, along with human milk, oligosaccharides, and exomes. And these are all promising future therapy like stem cell administration, aryl hydrocarbon receptor agonist for prenatal prevention of NEC, along with anti-cytokine therapy and growth factor therapy. So this study was published in 2021. In this, they studied maternal aryl hydrocarbon receptor activation as prenatal intervention against NEC, and it was concluded that AHR signaling is critical in NEC development, and maternally delivered AHR-based therapies may alleviate NEC. So the field of NEC has seen major advances over the past decade. To move this field forward, 4 major areas of research need to be addressed. These include search for TLR4 dependent molecular pathway, second, discover effects of metabolism on the prevention of NEC, and third is prediction of NEC development along with focus on maternal factors, and fourth is prevention of long-term complications of NEC. So at last, conclusions that there is a unifying theory of NEC development that involves bacterial signaling by TLR4 in the premature gut epithelium. Role of NEC is there in inducing damage to the brain and lung. It is necessary to actively intervene against CSD, sepsis, and blood transfusion, as these are the important risk factors for NEC. Breastfeeding should be highly advocated, and probiotics are given to adjust the balance of intestinal flora. The prospects of using stem cell therapy and breast milk derived exomes appear to be promising in future. So with these advances in the pathophysiology and management of NEC, we are hoping to create a world without NEC. Thank you.